Actually, we heard a lot already, and it's, so to say, a well-known topic, so it was not easy to prepare something which would sound, let's say, interesting. But okay, let's try. As we already heard, 1995 was a revolution, and we are celebrating a sort of we have a sort of a little celebration of 30 years of using this revolutionary approach to stroke. It was approved actually in 1996, and it was approved in Croatia in 2003. As I say, a small revolution. Well, I must admit the neurologists as a group are maybe a little bit introvert, a little bit inert, and also public. What they were thinking about stroke is, as you very nice showed on your picture, that this is something which you can just let go. And it was very, very hard to convince all public and politicians and for sure also some medical staff that stroke is an urgency. So I would say this was the first big step with thrombolysis to, let's say, see that stroke should be an urgency. So what we're actually doing, as we all know, in ischemic stroke, it is naturally a sort of a fibrinolytic state, and we also have our intrinsic TPA, and it was logical to think that adding RTPA to this intrinsic phase would actually help and solve the problem. There were some studies with streptokinase, as you all know. There have been actually halted prematurely because it was a significant increase in the rate of symptomatic intracranial hemorrhage and no significant improvement in functional outcome. Anyway, RTPA was then in 1996 approved, and for sure it had some negative points like raised rate of symptomatic intracerebral hemorrhage. However, the analysis of the NNDS trial data actually demonstrated that the benefit of RTPA was independent of severity of initial neurologic deficit, age, gender, presumed stroke type, and actually the benefit was much more obvious and significant than a harm. So, as I said, it was not easy to, let's say, implement this method, this way of treating in, let's say, everyday's life. I remember in our own hospital, we had some problems when we were talking the first time about thrombolysis. Our head at that time said that this method would never come into his hospital because it's actually too dangerous. And maybe the first problem with thrombolysis was to get more patients. And for sure, extending time for thrombolysis was one of the steps which could help in this. We have already heard about this. We can pick a lot of studies. I've picked this one from March this year. And basically, all the studies showed that IVT for stroke, even beyond 4.5 hours, led to increased odds of excellent and good functional outcomes compared with standard medical care. For sure, sub-analysis showed that if patients were selected with perfusion imaging, the results were better. If tenecteplase was used, the results were also even better. And there is another study showing actually also very recent one, showing actually nearly the same result. So at the end, the conclusion could be that today we can thrombolyze nearly everybody if we have a good or, let's say, sufficient neuroimaging, advanced neuroimaging method. The next try to help RTPA to be more efficient or to produce, so to say, less harm was to combine it with some neuroprotective drugs. There are also several studies. We in our center had also one study with the neuroprotective drug, which is cerebrolizine, on a very small group of patients, but we published the result which showed less rate of hemorrhagic transformation. We do know today that hemorrhagic transformation is even a symptomatic one, can lead to some, can impact some worse outcome in the treatment of stroke. And these results were actually also confirmed on some larger group of the studies. Then it was a combination with drugs which can actually enhance the treatment or enhance the benefit of thrombolysis. However, like the phase 3 of most trials showed, adding a direct thrombin inhibitor, argatroban, or a glycoprotein 2B3A inhibitor, eptifibatide, didn't lead to benefit to those patients. So this study was not positive in this sense. Then for sure playing with dosage in a try to get the same benefit and to do less harm to the patients. And this playing with dosage and using lower dosage also didn't show statistically any benefit. Finally, we got thrombectomy. And thrombectomy was, as already said, the second big revolution. For sure, especially for the patients who had large vessel occlusion. And the first step was well, why do we need thrombolysis if we have such a miracle method? And as already heard, I will not go into details anymore. Still, today, there is no significant proof. There are some proofs like direct MT trial, which show that even without thrombolysis, the patients can have the same results of treatment. But still, as we know, in the guidelines, we do have intravenous thrombolysis. The discussion goes in different ways. Pro-thrombolysis, there are facts or meanings that IVT may soften the thrombus, may reduce the duration of procedure, may reduce the number of passes, which is for sure for discussion. And on the other side, we have the con group, which says that it can lead to migration of a thromb, it can lead to increased bleeding complication, increased treatment costs, delayed initiation of mechanical thrombectomy, and so on and so on. Well, when we have already heard, when we look to the studies which were analyzing to the meta-analysis of the trials, then we still have the final conclusion that mechanical thrombectomy with intravenous thrombolysis actually does some benefit and improves the prognosis of the patients with acute ischemic stroke. But there is, I'm sure, a lot to discuss in the future. Then we have a new product, new agent, a new rising star. This is a tenecteplase, which for sure has some advantages over alteplase, considering the way of even the way how it works, and considering especially the way how is it given to the patients, which is in bolus, which is much, much shorter. I will not go into the details about tenecteplase because we have a lecture in the afternoon about, but for sure this is something which can, let's say, improve especially the time which is used to give alteplase, and which also showed some benefits, especially in the therapy, bridging therapy for the patients who are candidates for thrombectomy. There are always doubts, and there are always group of people who doubt even the effect of thrombolysis itself. So this table, I think, went around the world, and you see a lot of red and very few green spots in the table. And in the same work, it was actually stated that, okay, there are some results or these curves which are showed on this slide, that the curves are similar, but the dose of TPR is slightly better than dose of placebo. But at the end, the conclusion was that there is no much difference between TPA and placebo, that it disappears, and after some time, and that does suggest confounders in this graph. So even there are some very serious recommendations that there is actually no proof that there is benefit in giving thrombolysis, and also there is a lot of harms. One of the recent analyses of all those results is the analysis of pharmacist, Professor Andrew Webb, who very thoroughly reacted of all these statements and of all these results of the meta-analysis. And actually what his final conclusion was that thrombolysis does improve outcome if we choose the right patients, which is for sure, I think, the real philosophy which we should take to our meaning. And this is something which we already saw, but it's a little bit different. And it is the truth that thrombectomy, meaning stroke intervention, early stroke intervention, early endovascular stroke intervention has a number needed to treat. This is a very nice parameter, which I also like very much, because it really shows the differences between different procedures, which we are maybe not aware of. And this is maybe the best procedure actually we ever had, considering different procedures, because the number needed to treat is really, really very low. But let's take into account also that IVTPN given in the first 3 hours has a number of 8, which is also a very, very low number comparing to other procedures and comparing to other methods. And finally, as we heard also today, we still have proven the efficacy of mechanical thrombectomy, let's say, only in large vessel occlusion. For sure, it's not only, I'm aware of this, but we also have to be aware of the statistics and of the prevalence of large vessel occlusion. To the best of the statistic, it's 1/3 of our patients. Maybe even less, but okay, let's stay with 1/3. And that's why we still have intravenous thrombolysis in the guidelines. And that's why we actually still treat like 70% of the patients with IV thrombolysis, as they don't have any other treatment at the moment. Until you guys develop the devices or prove that those devices in a distal occlusion are also better than medical treatment alone. So now back to Croatia. Where are we in this story? We heard what happened with the network of endovascular centers, and as I said, I'm much more optimistic than maybe David was, and I see the big difference between stroke care in Croatia in the last years. This is how it looked like in 2018. As David said, we had 2 endovascular centers in Zagreb and 1 in Split, and only few hospitals which were even giving thrombolytic therapy. What we have 2023 is 5 centers and a lot of more these red dots. And even more important, this is a table from Rescue Registry, which we every year publish or give as a poster in European Stroke Organization Congress, and this is what happened from 2019 and 2023. So what you can see, we have intravenous thrombolysis, which is actually at the moment a little bit less than the year before. This is still 2023, so we don't have last year yet. But we have a percentage of 13.6 patients who are thrombolyzed. Thrombectomy is very, very popular in Croatia, and a lot of patients do not receive thrombolysis, even if it's indicated. So we don't have a problem of giving thrombolysis after 4.5 hours. We have a problem to convince our primary centers to give thrombolysis to the patient who is a candidate for thrombectomy, because thrombectomy is going really well, and as you can see, we have 7.8% of patients who receive thrombectomy, and as you know, the stroke action plan till 2030 should be 5% of patients 5% of stroke patients who received endovascular or thrombectomy. And also talking about mortality, this is the mortality rates which was really going down through these 5 years. So as I said, on Monday we will start, I hope, to implement also our national registry, and I do hope that we will be able to show this epidemiology and statistical results even more accurate. Thank you very much.